we're going to rapidly revise all important questions, volatile facts, and high yield topics. Also, most expected topics are going to be covered. In Auricle, we have recorded classes, we have live classes, practical sessions, exam module, and also hard copy books. In the recorded classes, we facilitate flexible learning along with convenient revision. Live classes, there is in-depth coverage and interactive learning by use of MCQs and Viva and more. In the express exam module, all important questions, previously asked questions with 10 years questions are covered in just 20 hours. There is a one-on-one doubt clearing session. There are hard copy books also available and a question bank with 3 levels of expertise, including questions from previous year FMG exams, NEET PG exams, and also for Proff exams. There are practical sessions also available. These are the plans which are available in the website. So, in this lecture, we're going to discuss a few renal pathology questions. So, this is the first renal pathology question. This is the first long essay question which we are going to discuss. Okay, so in this question, we can see that there is a 50-year-old with a facial puffiness. Okay, there's a 50-year-old with facial puffiness and proteinuria. So we can see here that this individual has proteinuria. So what could be the causes? We already saw that there were 2 important things which you have to remember, right? 2 important syndromes which you have to remember in kidney. One is the nephrotic syndrome and one is the nephritic syndrome. So the glomerulonephritis are going to revolve around the nephrotic syndrome and the nephritic syndrome. So we know whenever there is nephrotic syndrome, we're going to have proteinuria, and the proteinuria amount is going to be more than 3.5 gram per day. Okay, whereas in nephritic syndrome it is going to be less. So proteinuria, facial puffiness is because of edema as a result of proteinuria. Okay, so this is a case of nephrotic syndrome because significant proteinuria is there. So now we have diagnosed and we have the clues for diagnosis: proteinuria and facial puffiness. These are the clues. One clue for diagnosing nephritic syndrome is hematuria. Whenever the patient has hematuria or the patient has hypertension, you can think of nephritic syndrome. What are the causes of nephrotic syndrome? So we have to discuss the causes of nephrotic syndrome. Okay, what are the causes of nephrotic syndrome? Most important cause of nephrotic syndrome in a pediatric age group is minimal change disease. Okay, minimal change disease is the most important cause of nephrotic syndrome in a pediatric age group. In adults, the most important cause of nephrotic syndrome is focal segmental glomerulosclerosis. What is the pathophysiology behind these changes? It is effacement of food process. You can see effacement of food process in these cases. Okay, what do the food processes do? The food processes are something like this around the basement membrane. The important function of these food processes in the glomeruli is absorption of protein or albumin, which is the most common protein. So when albumin is not absorbed, then we are going to have proteinuria. So effacement of food process is somewhere where these food processes are something like this, but they fuse together. They fuse together and become like this. So the surface area for absorption becomes reduced and there's going to be proteinuria. This is the main pathophysiology behind minimal change disease, which is common in pediatric individuals, and focal segmental glomerulosclerosis, which is common in adults. Other causes of proteinuria, we have membranous nephropathy. Membranous nephropathy is a cause of proteinuria in adults as well. Membranous nephropathy can be primary as well as secondary. Primary membranous nephropathy can be caused by a protein which is known as PLAR. So antibodies against this PLAR protein can result in primary membranous nephropathy. Secondary membranous nephropathy, as the name says, has multiple causes. It can be caused due to infections such as HIV, hepatitis B, hepatitis C, etc. It can also be caused by drugs and SLE. So other diseases, other systemic diseases like another cause is membranoproliferative glomerulonephritis. So these are a few causes of nephrotic syndrome. And since it is a 50-year-old, this is an adult nephrotic syndrome. What is the most common cause of nephrotic syndrome in adults? It is FSGS. So these are the causes of nephrotic syndrome in adults. The next question which we are going to discuss is again nephrotic syndrome and what are the important causes in the pediatric age group. In pediatric age group, as we saw, the most common cause is minimal change disease. Why is the name minimal change disease? Because when you see light microscopy is normal in minimal change disease. So when you see a kidney biopsy, there is very minimal change in the normal light microscopy. That is why the name is minimal change disease. But when you see the same case in an electron microscope, you will see what is called as food process effacement, which we talked about. So first, focal segmental glomerulosclerosis, even though it can occur in adults commonly, it can also occur in a pediatric age group. And then membranoproliferative glomerulonephritis. Congenital nephrotic syndromes are common in pediatric age groups. Okay, so congenital nephrotic syndrome is a very important cause in pediatric age group. What is the pathophysiology? As I already told that there is food process effacement. Okay, congenital nephrotic syndrome, two types of genes are involved, NPHS1 and NPHS2. Two genes are involved in congenital nephrotic syndrome. So the next long essay question, which is commonly asked, which was also previously asked, is the tumors of kidney. Okay, tumors of kidney. This is a very vague classification. So usually there is a renal cell carcinoma. There are three important types of renal cell carcinoma that you have to know. The first and most common one is the clear cell renal cell carcinoma. The second one is papillary renal cell carcinoma. And the third one is chromophobe renal cell carcinoma. Okay. These are the common types of renal cell carcinomas. These usually occur in adult age group. Okay. Wilms tumor is a type of renal tumor. It is also known as nephroblastoma. Wilms tumor is also known as nephroblastoma. Nephroblastoma is the most common pediatric tumor which can occur in the kidney. It is a pediatric tumor which can occur in the kidney. As the name says, nephroblastoma. So what will be seen in these tumors? You will see blastemal components. Blastema or blastemal components will be seen in these tumors. And another type of carcinoma is transitional cell carcinoma. As you can remember, transitional cell is a type of cell which can be seen in bladder and renal pelvis. Okay, so renal pelvis and ureters have transitional epithelium. So you have kidney and this is the renal pelvis. And these are the ureter, and ureter will join into the bladder. Okay, so this is the part where transitional carcinoma can arise in the kidney, either in the renal pelvis where the ureter joins the kidney. So this is the transitional cell carcinoma. But most commonly, transitional cell carcinomas are tumors which arise in the urinary bladder. Okay, so what is the etiopathogenesis of these tumors? And what are the morphology? That's what we are going to discuss now. First of all, clear cell. Clear cell carcinoma is the most common tumor of the kidney, most common renal cell carcinoma type. As the name says, you will have clear cells. The cells are clear. Why are the cells clear? Because there is glycogen deposition in these cells. That is why the cells appear clear. And there are increased vasculature. You're going to see lots of blood vessels in and around the tumor cells. Why? Because the pathogenesis of clear cell carcinoma is there is VHL gene mutation. Okay, VHL is von Hippel-Lindau gene mutation, and this mutation, this encodes a protein which is known as HNF alpha. So HNF alpha is nothing but a hypoxia, this sorry, it's not HNF, hypoxia inducing factor alpha. So the cells will assume that there is no blood supply because this is an hypoxia inducing factor. It will induce hypoxia. And the cells are going to assume that there is no blood supply in the said tissue. And because of that, the cells are going to increase production of blood vessels to increase oxygen supply in turn by producing something which is known as VEGF, vascular endothelial growth factor. So these factors will go and increase blood vessels. So as a result, what is going to happen is the tumor will become extremely vascular. So lots of blood vessels will be seen in this tumor. Okay, so that is the pathophysiology behind clear cell carcinoma. So the characteristics we know, the deletion of 3p. 3p is the part in the gene where VHL gene is present. So VHL gene will induce something known as HIF1 alpha. So hypoxia inducing factor resulting in the production of increased blood vessels. Apart from that, there is gain of chromosome 5 and loss of 8p and 14q also. So what is the, how do these cells look? There are compact nests of tumor cells with clear cytoplasm separated by delicate vasculature. Several architectural patterns are seen, including solid, alveolar, and acinar. Okay, this is fine, but remember the pathophysiology. Papillary. Now, next one is papillary. Papillary is the second most common. Chromophobe is the least common. So, papillary, you can say by the name that there are going to be lots of papillary structures. Okay. So, there are microscopically papillae. Alright. What is the genetic abnormality which is seen? Remember, there is in a clear cell, there is 3p. Okay. In papillary, there is trisomy. That is trisomy 7 and 17. Okay. And also you can see in hereditary papillary carcinoma, okay, when papillary carcinoma occurs in a hereditary fashion, in hereditary papillary carcinoma, you're going to see met proto-oncology mutations. If it is a hereditary condition, so papillary, second most common, trisomy 7 and 17 mutation, and met proto-oncology mutation is going to be seen in papillary carcinomas. Then chromophobe carcinoma. In chromophobe is nothing but these cells look like plant-like. So that is what chromophobe means. Basically, how these cells will look is you're going to have cell with a thick cell wall. The cell wall is going to be very thick. The cell wall is going to have very thick because we know plant has a very thick cell wall. Similarly, chromophobe carcinomas will also have a very thick cell wall. This nucleus is going to be very dark. Okay. And the cells will have granules. So this is how chromophobe carcinoma cells will look. You can see in this image here, and the cell wall is little bit extra thick. And look at this nucleus over here. It is very big and dark. And lots of nuclear abnormalities you can see. And few granules can be seen in the cytoplasm. Some are clear, some are granular. So this is the And this is how chromophore carcinoma will look. Cells are large, polygonal with finely reticulated cytoplasm, distinct cell borders. This is very important. You can see everywhere that there are distinct cell borders. Okay, sometimes there can be a perinuclear halo also surrounding the nucleus, a clear space which is known as a perinuclear halo. This can also be seen. So what is the abnormality, chromosomal abnormality? Loss of chromosome Y, 1, 2, 6, 10, 13, 17 and 21. So these are a few chromosomal abnormalities. Okay, so these are a few important renal cell carcinomas, the genetic mutations and histological patterns which you have to remember in renal cell carcinomas. Okay, so now let's move on to a few short essays. The first one is renal changes in diabetes or diabetes nephropathy. So whenever discussing renal changes of any disease, we're going to divide it into glomerular changes, tubular changes, and changes in the blood vessels. Okay. So glomerular changes. The first important change is glomerular hypertrophy, and why also thickened basement membrane. So these are the most important primary first changes which occur in the glomerular in renal in diabetic kidney. First one is glomerular hypertrophy, increased size of the glomerulus, and then you're going to have prominent glomerular basement membrane. Okay, after that, mesangium. We know this is the glomerulus, this is the glomerulus, and these are the arteries. This is the glomerular basement membrane. Okay, you can see here lots of capillaries will be there in the basement membrane, and this is the mesangium. Okay, mesangium. This is a mesangium. So mesangial expansion, that is the second change which happens after glomerular hypertrophy and glomerular basement membranes. And then we have nodular sclerosis. Sometimes what happens in between, you have hyaline droplets depositing here, forming a nodular sclerosis. Okay, there are these capillaries will become overly dilated and form aneurysms also. So that is capillary microaneurysms, you can see here. And capsular drop and lipohyaline caps can also be seen. Lipohyaline caps can also be seen in light microscopy. Okay, so first, what are the first changes which occur? Glomerular hypertrophy, and then basement membrane thickening or prominent basement membrane, and then mesangial expansion in this area, and then nodular sclerosis. This is also known as Kimmelstein-Wilson nodules. Okay, and then capillary microaneurysms can occur. These capillaries can expand and form microaneurysms, and then you can have capsular drops. In the tubules and interstitium, what can you see? Okay, you have glomerulus here, and then you're going to have tubules here. You're going to have tubules here. You're going to have the proximal tubule, and then the loop, and then the distal tubule, right? So what are the changes in the tubules? Atrophy of tubules. Prominent tubular basement membranes also, and you can have fibrosis of these tubules. What are the changes in the blood vessel? There will be some blood vessels, right? So hyalinosis of the afferent and efferent artery. So hyaline changes are very important in diabetes. You can see capsular drops are because of hyaline deposits, lipohyaline caps because of hyaline deposits, nodular sclerosis, Kimmelstein-Wilson nodules are also hyaline deposits. So hyalinosis of the afferent arterioles and fibrosis of the arteries. These are the changes in the artery. This image here, this is an image of a hyaline drop. This is a hyaline drop. Or a capsular drop. This is also known as capsular drop. Okay, so you can see here near the glomerulus, you can see here this is the glomerulus. These are tubules in the kidney. This is the capsular drop. Okay, this image shows expansion of mesangium. Okay, this is nothing but mesangial expansion. You can see there is little bit because of this Hyaline deposits, it is expansion of mesangial area. Okay. Now this image here, this is a lipohyaline cap. This is the glomerulus. Surrounding the glomerulus, there are lots of hyaline deposits. And because of this hyaline deposits, this is a cap-like formation is there. This is known as a lipohyaline cap. Okay, and finally, these are the Kimelstein-Wilson nodules, KW nodules, hyaline deposits, everything. So these are KW nodules or Kimelstein-Wilson nodules. Okay. So this is a normal glomerulus. You can see here. Glomerular basement membrane is normal. This is a diabetic glomerulus. You can see how thickened the basement membrane is. This is how the normal mesangium looks here. Okay. And then you can see there is mesangial hypertrophy over here. Extra mesangium. And you can see arteriolar hyalinosis. We saw there were two arterial findings, arteriolar hyalinosis and fibrosis of the arterioles. So you can see here there is arteriolar hyalinosis. Okay. Okay, so the next short essay question is acute tubular necrosis. So when does acute tubular necrosis occur? During ischemia, whenever there is ischemic injury. Okay, whenever there is ischemic injury, whenever there is reduced blood supply to the kidney, we can have tubular necrosis, drug-induced injury, toxin-induced injury. So these are the causes of acute tubular necrosis. What will happen? Afferent arteriolar constriction, decreased glomerular filtration rate because of ischemic injury or any other causes, drug-induced or toxin-induced injury, can result in decreased glomerular filtration rate. So if blood is not going in, what will happen? These ischemic or toxic insult can also happen, and the cells will start shedding, causing obstruction because of tubular injury. So you can see here, these are nothing but necrosis. From your general pathology, you can remember what are the features of necrosis, right? You can see that nucleus is somehow lost here. These are a few cells with nucleus. But there are a few cells here without nucleus. So we know what are the three important nuclear features of necrosis. We have pycnosis, karyorrhexis, and karyolysis. Correct. And also, what is the other feature of necrosis? Necrosis, the cells are going to be more eosinophilic because of loss of nucleus. So you can see all these features here. Here, a few cells are lost their nucleus, and you can see that they are more eosinophilic compared to these cells which have the nucleus. Okay, so these are the features of necrosis, which you can see in acute tubular injury in histopathology. Now, another short essay question is chronic pyelonephritis. So first of all, what is the definition? Chronic, it is a chronic condition and it is inflammation of the kidney and tubules. Okay, so this is pyelonephritis, inflammation of the tubules. So where do we see chronic inflammatory cells? It's a chronic condition. So what kind of inflammatory cells are you going to see? Chronic inflammatory cells. Most importantly, lymphocytes and plasma cells along with a few macrophages. So these are the macrophages or monocytes. Okay, so these are going to be the chronic inflammatory cells in the interstitium, tubular atrophy or dilatation, and finally fibrosis. You can see. Most important feature of chronic pyelonephritis is dilated tubule which have these colloid casts inside them and they start resembling the thyroid gland. Okay, you remember the thyroid gland, right? There was a gland-like structure here and they were surrounded by cuboidal epithelial cells, and inside these epithelial cells there was colloid. Okay, so this was how thyroid gland look. So this kidney will start resembling a thyroid gland. So this is known as thyroidization. Okay. In the later stages, these inflammatory cells will lead to fibrosis. We know inflammation is going to ultimately eventually lead to fibrosis in the later stages, and the kidney will even become dysfunctional. So this is the thyroidization of tubules, which you can see in chronic pyelonephritis. And what is the reason for that? Colloid casts. Okay, now we are going to discuss types of renal calculi and how these renal calculi are formed. First of all, renal calculi are always formed in a supersaturated urine. So whenever urine is supersaturated, what does supersaturated mean? The amount of water content in the urine is very less and the amount of salt content in the urine is high. Salt in the sense dissolving substrate concentration is very high. So the urine becomes increasingly saturated. The urine becomes increasingly saturated, and because of that it becomes super saturated. And because of super saturation, what will happen is these particles are going to get crystallized because of the lack of water content. So crystallization will happen, and eventually these crystals will get aggregated to one another. So crystals are getting formed and crystals will start aggregating. They will become bigger crystals. These smaller crystals will start aggregating and become bigger crystals. Okay. And then they will start growing into bigger stones. So that is how renal calculi is formed. Now, what are the types of renal calculi? Calcium oxalate crystal is the most common type of renal calculi. So this is the most common type of renal calculi. When you see it under a microscope, you can see that these crystals are envelope shaped. You can see a envelope shaped crystals. These are radio opaque crystals. You can easily identify them in the X-ray. Okay, calcium phosphate crystals can also be seen. They are amorphous crystals. Again, radio opaque crystals can be identified. Radiolucent, only two crystals are radiolucent, and they are uric acid crystals and cysteine crystals. Only these two crystals are radiolucent. Okay, so uric acid crystals are diamond shaped or rhomboid shaped crystals. Okay, these crystals can also be seen. Importantly, triple phosphate crystals, they are staghorn. They're also known as staghorn crystals. Okay, you can see that there is a staghorn type of appearance over here in these crystals. Okay, that is why they are known as staghorn crystals. They have a coffin lid shaped appearance when you see under a microscope. They are also radio opaque crystals. Cysteine crystals are usually hexagonal shaped crystals. When you see under a microscope, these are radiolucent. See, radiolucent crystals are very difficult to identify in X-ray. So they are not easily identified in X-ray. You have uric acid and cysteine crystals which are radiolucent. Now we are going to see a few kidney changes associated with hypertension. So two important types of hypertension which you have to remember is one is the benign nephrosclerosis. Benign nephrosclerosis. In benign nephrosclerosis, you can see that this is an artery. Okay, this is an artery, and you can see hyaline deposits over here. These are all nothing but hyaline deposits. These pink deposits are nothing but hyaline deposits. So this is also known as hyaline arteriosclerosis. Okay, so this is seen in benign nephrosclerosis, hyaline arteriosclerosis. This here you can see there is an onion skin thickening. There is a layering in these arterioles. There you can see layering over here, right? So this is known as onion skin thickening of arterioles, and this is seen in malignant nephrosclerosis. This is seen in malignant nephrosclerosis. So these are the two important changes which you have to remember in benign and malignant hypertension. Now, what are the causes of hematuria? So this is an important question. We know that whenever there is hematuria, you have to think of nephritic syndrome. Right. So what are the causes of hematuria? We can split it into glomerular causes, non-glomerular causes. And hematuria can not only occur from kidney, but you can also see it from the ureters, bladder, prostate, and urethra. So there are so many important causes which you have to remember. Glomerular causes, IgA nephropathy, and many types of glomerular nephritis which can be associated with nephritic syndrome. And then Alport syndrome, thin basement membrane disease can also result in hematuria. So renal stones are an important, very important and most common cause of non-glomerular hematuria. Tumors can also cause trauma, of course, and renal papillary necrosis can also result in hematuria. In the urethra, of course, we have trauma and infection. Bladder, tumors, and infection can result in hematuria. Benign prostatic hyperplasia and prostatic cancer can also result in hematuria. Okay, so these are a few important causes which you have to remember for hematuria, and also always try to draw a diagram over here and split the causes into glomerular, non-glomerular, ureteric cause, and bladder. Okay, so if you just know the anatomy, you can draw and point out what are the causes in each area. Next one is horseshoe kidney. So you can see here that during the development of kidney, you can see that both kidneys are separate. But during the development, the mesonephros, if it does not separate, there is a fusion in the lower pole of the kidney. So this is known as a horseshoe kidney. Horseshoe kidney is nothing but a fusion in the lower pole of the kidney. Whenever there is a fusion in the lower pole. So what will be the complications of this kind of a condition? Hydronephrosis can happen because of retention of urine, because uh, because of retention of urine you can have hydronephrosis. These patients are very much prone to kidney stone development and prone to infection, and also tumors such as cancers, kidney epithelial cell tumors, carcinoid tumors, and Wilms tumor can occur in patients like these. So fusion of the lower pole of the kidney, there are complications such as hydronephrosis, renal stones, and these patients are very much prone to infection, and even tumors can be a very rare complication which can be arising from horseshoe kidneys. Now, another short answer question we're going to discuss is azotemia and uremia. Okay. Whenever there is renal failure, what is the function of kidneys? The function of kidneys is to excrete toxic metabolites. So one of those metabolites, few of those metabolites are nitrogenous wastes. Okay, nitrogenous wastes have to be eliminated. Also, urea should be eliminated. So these are the things which are eliminated by the kidney. But whenever there is a end-stage renal disease, the kidney is not able to perform its function. The filtration rate is low and the kidney is not able to excrete these wastes. So what is going to happen is they will get accumulated in the blood. They will get accumulated and the blood levels will arise. Okay. Azotemia is nothing but an increase in blood levels of nitrogenous compounds. Okay, nitrogenous compounds including urea. So this is measured by something which is known as blood urea nitrogen. The most important difference between azotemia and uremia is azotemia does not have any clinical symptoms. Okay, no clinical symptoms are associated with azotemia. It is just a laboratory finding with increased blood urea nitrogen levels due to renal disease. Okay, so this is azotemia. Uremia, whenever you hear the word uremia, it is a clinical syndrome. Clinical syndrome. So whenever, definitely yes, PUN levels will rise in uremia. Yes, and blood urea levels will rise in uremia. Yes, but apart from all these things, you are going to have symptoms in uremia. What are the clinical symptoms which you will have? Abdominal pain, urologic symptoms. There is going to be neurologic symptoms like delirium, delusion, and delirium, yes, you're going to have due to, okay, neurologic symptoms will be there. Okay, skin symptoms will be there, such as itching. So this is the most important difference between azotemia and uremia. Clinically symptomatic uremia, clinically not symptomatic, only increase in nitrogenous metabolites, then it is azotemia. Okay. So next is microalbuminemia. Microalbuminuria. Okay, what is microalbuminuria? Normally there should be no albumin in the urine. Albumin is usually absorbed, right? So there is a normal threshold, but usually very little amount of albumin is excreted in the urine. What is the normal amount of albumin that can be excreted? It is less than 30 milligram per 24 hours. Okay, so this is the normal amount of albumin which can be excreted in the urine. So when 30 to 300 milligram of albumin is excreted in 24 hours, this is what is known as microalbuminuria. Okay, whenever more than 300 milligram of albumin is excreted in 24 hours, this is known as macroalbuminuria or just albuminuria. What is the use of measuring this albuminuria? What is the purpose of measuring albuminuria? It is important to measure albuminuria because it is one of the first important signs for diabetic nephropathy. Okay, so diabetic nephropathy, a very important sign is albuminuria. Apart from that, in hypertension, you can have albuminuria. So it is also an important indicator of or predictor of cardiovascular diseases. Okay, so these are the reasons why you should measure microalbuminuria. So normal is less than 30 mg, no albumin in the urine. 30 to 300 is the definition of microalbuminuria, 24 hours, and more than 300 is albuminuria. Okay, so you have to measure, you have to take 24-hour urine. You have to collect 24-hour urine and measure this amount in a 24-hour urine sample to measure albuminuria, microalbuminuria. Okay, so that is it. We're done with most of the long answer and short answer questions for today. We'll see you in the next session tomorrow. Thank you so much.